Harley Street Fertility Centre, Mauritius, is the only dedicated fertility centre on the island. More than 1,500 babies have resulted from treatment here.
Hello, I'm Dr. Salgar Sarfaraz. I work in Harley Street Fertility Centre as a consultant gynecologist and obstetrician.
Chers téléspectateurs de Télé+, bienvenue à cette émission spéciale organisée conjointement par Télé+ et Défi Santé. Aujourd'hui, dans l'émission Mieux comprendre, nous proposons un sujet qui est extrêmement important pour beaucoup de familles, c'est le traitement fertilité. Nous connaissons que beaucoup de familles, pour beaucoup de couples, gagnent des enfants, c'est très important pour compléter la famille. Mais seulement, voilà, aujourd'hui, plus qu'ils aiment, fertilité, il devient un vrai problème. Qui fait? Parce que nos rythmes de vie, nos styles de vie, l'alcool, cigarettes, obésité, divers types de pollution qui existaient dans les mondes modernes, mais aussi problèmes physiologiques qui disent capable et puis, c'est très souvent aussi une question de choix, l'âge. L'âge qu'un couple choisir pour gagner un enfant, parfois pour une raison moyenne, parfois pour une raison pratique, mais aussi parfois pour une raison carrière. Au fait, tout ça, facteur-là fait que problème infertilité, aujourd'hui, est très prévalent dans nos sociétés. Ban statistique capable s'y apprend nous-mêmes. Jusqu'à 14% de couples capables de faire face à une forme de problème infertilité dans les mondes. Ça fait un couple, le 6, qui besoin à un moment ou un autre, aller un spécialiste pour comprendre qui manière il peut traiter ce problème, c'est gagner des enfants. Seulement, comme on connaît, aujourd'hui, la bonne nouvelle, c'est qu'il y a une solution. Seulement, c'est gagner des enfants, traite l'infertilité, il quand même reste un processus qui demande beaucoup de temps, beaucoup de patience, beaucoup de professionnalisme, beaucoup de soutien et surtout, il passe par un bon diagnostic professionnel. Pour connaître vraiment qui nous peut le traiter. Et a fait traitement à l'extérieur, et a choisi pour faire dans Maurice, dans le service public, dans le service privé, mais dans tous les cas, il demande un suivi continu. Dans l'édition spéciale Mieux comprendre là, nous finalement des experts audits, l'eau plateau Télé+, des spécialistes Harley Street Fertility Centre de Floréal, un service qui audit peut célébrer ce 15 ans dans Maurice. Dans 15 ans, je fin aide plus que 1500 jolis petits babas vivent au monde, donc je fin aide beaucoup de couples sur le monde de problèmes infertilité. Le directeur médical, le docteur Rajat Goswami, lien spécialiste qui fin offert ce service dans Maurice pendant plus que 20 ans. Welcome to the program, Dr. Goswami.
Thank you very much.
Nous avons aussi Harley Street, ce obstétricien, gynécologue et spécialiste in vitro, le docteur Salgar Sarfaraz Nawaz. Welcome to the program, Dr. Nawaz.
Hello and thank you.
Et nous avons aussi le manager du centre, Madame Francesca Comarmont, qui là, et lui aussi, il peut expliquer nous un peu qui a été service gagné dans le centre.
Merci.
Donc, je peux nous mieux comprendre ce que c'est que traitement infertilité et surtout guide ban téléspectateurs qui visent ce type de service-là vers ban solution qui existait à votre disposition. Donc tout de suite, je tourne vers le Dr. Goswami. Dr. Goswami, first of all, can you explain to us what Harley Street Fertility Centre, what kind of services you give in Floréal?
Well, the Harley Street Fertility Centre is the only fully dedicated fertility centre on the island. We provide any and every fertility treatment possible, except for donor sperm, donor eggs, which we are unable to provide as yet because of the government regulations. But the important message I need to get across to patients is that they must have a clear diagnosis before they embark on any treatment. And in my understanding, unexplained infertility does not exist. It is undiagnosed, and we always get a diagnosis. We guarantee patients a diagnosis. We cannot guarantee pregnancy, but we can guarantee diagnosis. And once we have a diagnosis, then we discuss treatment options.
So, what are the main reasons that in Mauritius people have difficulty in getting pregnant?
In 1 out of 3 couples, the problem is on the male side. In 1 out of 3 on the female side, and 1 out of 3 it's on both sides. So half the time there is a problem on the male side as well.
So very often it's a kind of misconception then that the problem is a lady's problem. It might be a couple problem or a man's problem.
Correct. I think that with male infertility, people were not prepared to accept this for social reasons and for macho reasons. But at the end of the day, 50% of the time, there is a problem on the male side. And this is happening because fertility is declining over the years. Over the last 50 years, male fertility has been falling, partly due to stress, partly due to lifestyle, maybe bad diet, pesticides, we don't know, many factors. Female infertility in Mauritius seems to be more due to conditions like endometriosis, and fibroids, and now age is also coming into play because many girls are delaying childbirth, either because they get married late or haven't found the right person, or for career reasons. They delay trying to get pregnant, and this again is decreasing their fertility.
So generally, what have you found out at the clinic? At what age generally do couples take cognizance of their issues and come to you? At what kind of age?
When I first came to Mauritius, most of the patients I saw were below 35. Now, 15 years later, I find that at least half are above 35. So it is changing. Initially, I was very happy because my patients in London, 70% were over 40. So I think this is a Western disease of delaying childbearing, and this is now happening in Mauritius. And the birth rate in Mauritius is dropping dramatically, and we're trying to increase that as much as we can.
So, donc, c'est qui Dr. Goswami peut dire nous là, il peut dire nous qui dans ban problème infertilité, un tiers problème là l'icôte ban monsieur, un tiers problème là l'icôte ban madame et un tiers problème là l'icôte ban couple. Et il peut dire nous aussi qui en général ban dimoun dans Maurice de plus en plus je peux venir vers autre solution à prendre problème infertilité de plus en plus tard. Et certainement le docteur peut dire nous est-ce que doctor, so we were saying how does the fact that people, how does the age of a person impact the efficacy of treatment and impact on the rate of success of solving infertility problems?
The rate of success, the chance of pregnancy, the decrease in fertility is all related to age of the female partner. Men are privileged. Their sperm count doesn't start to fall until after 70 years of age. But in women, there's a limited lifespan, reproductive lifespan. So in somebody between 20 and 30 is their peak fertility. By 35, fertility.
So what is the chance of getting pregnant in this time?
The chance of getting pregnant between 20 and 30 with in vitro or after fertility treatment is about 45%. By the age of 35, it drops to 35%. By the age of 40, it's gone to 20%, 25%. And below and above 42, we're down to 10% or 5%. So it falls very dramatically after the age of 40.
Donc, ce que Dr. Goswami peut dire nous là, il est extrêmement important qu'on comprenne ça parce que quand un dimoun peut décider pour faire un traitement fertilité, il est bien qu'à comprendre qu'entre 20 et 30 ans, ce sens pour réussir si on monte ce problème, il est 45%. Entre 30 et 40 ans, il vient à peu près 35-30%. Mais après l'âge 40 ans, il vient à peu près 10%. Doctor, so when a couple comes to you, what is the process they undergo? What are the first things that you do? And how do you guide the person through the process?
Yeah. First thing we need to find out is how long they have been trying to conceive. 15% of couples have difficulty in conceiving within 2 years, after 2 years. So we first take a good history to find out what has been happening, check whether the wife has regular periods, whether they're having intercourse on a regular basis, etc. After the history, we do echography, we do blood tests to check hormones. A woman who's having regular periods, we know that she ovulates, but what is the quality of her eggs? We test by doing hormone tests, blood tests. The same way, we must do a sperm test for the couple at the first visit itself, because 50% of the time the problem is the male factor. And if the first sperm test is not good, we do a repeat test. If the repeat test is also not good, now we know that this is confirmed. So once we've got a diagnosis, then we say, okay, what is the appropriate treatment? I would discuss with the couple, your chance of natural pregnancy, natural conception is based on your history. If everything was normal, each month you produce one egg. If that egg fertilizes and results in an embryo, your chance of pregnancy is only 10-15%. So we are doing better than nature when we provide fertility treatment. But at the same time, we have to look at what are the simplest way to achieve a pregnancy and the least expensive way to achieve a pregnancy for a couple. Some couples may need minor surgery. Some couples may need insemination, artificial insemination treatment with the husband's sperm. Others may need to go to in vitro. Others need to go to even more complicated treatments than in vitro, where we diagnose and test embryos. So all treatments are then tailored according to the patient's cause of infertility, and we discuss all the options with them and then plan the treatment forward. My aim with all couples is once we have a diagnosis, I would like to see them pregnant within 6 months.
Okay, normally it takes 6 months, or is it just a wish? Is it an average time frame that you're telling us, doctor?
Generally speaking, once we've done surgical treatment, if the patient doesn't get pregnant 3-4 months naturally, we move on to in vitro and hopefully achieve a pregnancy within 6 months. So I try and give a 6-month deadline to myself, but we cannot raise patients' hopes falsely, and they may not be able to afford to go through the treatment right away. So it does vary.
Yeah, donc là, c'est qui docteur Goswami peut dire nous, c'est qui normalement quand une couple vient guetli, il prend à peu près 6 mois. Lui-même, dans la clinique là même, je te mets un target 6 mois pour qui famille là réussit à gagner une solution qui est pérodée. Donc dans le premier mois, c'est-à-dire dans les premiers 3 mois, les poussées faire, les poussées stimulent l'écho madame là ou monsieur là pour qui naturellement est capable vivre enceinte. Et après ça, si ça n'a pas marché, il servit technique in vitro, et sa technique in vitro là, il existe une façon pour augmenter la sens fertilisation par une méthode qui science met à nos dispositions. Donc tout de suite, nous passons à une pause pub et nous retrouvons tout de suite après pour la suite de cette émission là.
Harley Street Fertility Centre, Mauritius, is the only dedicated fertility centre on the island. More than 1,500 babies have resulted from treatment here.
Hello, I'm Dr. Salgar Sarfaraz. I work in Harley Street Fertility Centre as a consultant gynecologist and obstetrician.
Donc, nous avec le docteur Rajat Goswami, qui est le directeur de Fertility Clinic Harley Street à Floréal, et il explique nous qui un couple bien faire quand j'étais là, un problème d'infertilité, qui type de traitement qui est disponible. Doctor, you know, you were telling us of the chances that we don't need to. The important thing is not to get the hopes of people too high. So, but they have to hope, right?
Correct.
But there's something I wanted to ask you, because many people have that misconception, as we said earlier, that it is only a women's problem. But you have said for women that the problem is something we can lay the finger on, because it's very specific. It's either the fallopian tube, or it's problems that we can identify. But it seems that for males, it's a little more. It's more difficult. Is that so? Is it more difficult to treat the male part of the problem?
Absolutely right. Sperm counts have been going down for the last 50, 60 years. The sperm is the smallest cell in the human body. It's a complex cell. The sperm cell has a head, a neck, a midpiece, and a tail. But it's the smallest cell in the body. It's a complex cell. Sperm production in the testes is a complex factory. In the testes, there may be about 20 kilometers of tubules which contains sperm maturing there. And so it's more complicated. In the past, before the days of in vitro, people tried tablets, hormones, this and that. Nothing really worked, because if you have a factory that is only manufacturing a particular quality of car, you cannot make it produce the top quality cars in the same way.
Yeah.
So we have to work with what we have. And the biggest development in fertility treatment that has happened for male factor is in vitro, where even men with hardly any sperm in their ejaculate, we can take individual sperm, inject into individual eggs, get fertilization, and they can father their own child. Before the days of in vitro, less than 10% of men were treatable with fertility treatment. Now, 99% are treatable. And the other 1% are the ones who produce no sperm in the testes at all. And then we have to look at donor sperm as an option. But otherwise, even men with zero sperm counts, most of them are still producing sperm in the testes, and we can use that sperm from the testes to fertilize eggs.
So you're telling me that the in vitro solution is to address the issue of sperm count mainly?
Yes.
So,
in fact, when in vitro was started, it was started for women with blocked tubes, with fallopian tube blockage, because you bypass the tube where the fertilization normally takes place. But in fact, all this male factor infertility, where we have very, very low sperm counts, we talk about sperm counts in millions. The normal sperm count is 60 million per mil. Anything below 20 million considered low. And we have men who are only producing 5 or 6 sperm in their ejaculate. Now, there's a huge difference. And no medication, no drugs, no vitamin supplements are going to bring them back to normal levels.
okay.
So we have to do in vitro in these cases.
So you don't use hormone treatment to treat sperm count issues?
I stopped using hormones to treat sperm count issues in 1982.
Ok, donc là, c'est qui Dr Rajat Goswami Pedianou, c'est qui le technique in vitro, c'est pour régler un problème qui normalement un missier gagné, c'est-à-dire un missier quand vous avez un sperm count qui bat. Donc cette technique in vitro, c'est surtout pour prendre sa sperme là, quand même qui a été bas li-bas, je prends un sperme et je t'extrais et dans un laboratoire, je t'injecte ça dans un ovum et je te fais fertilisation dans l'environnement laboratoire. Et donc c'est un problème, c'est une solution pour traiter le problème infertilité des messieurs. Hein, donc c'est aussi une misconception qui beaucoup d'immunes et na. Donc là, moi pour demander docteur là, mais justement docteur, what is the prevalence? So how often do you use in vitro?
If 1 in 6 couples have a difficulty conceiving, of those 1 in 6, at least half of them will need in vitro because of male factor or because of severe female factor situation like endometriosis or blocked tubes. Mm-hmm. So there are a lot of couples who would need high-tech fertility treatment, which we've been providing now for 15, 20 years here.
Mm-hmm. So we hear that when you do in vitro, first, before we get in depth with the in vitro treatment, what other options, what other treatments are offered at the clinic? What different kind of treatments are offered at the clinic?
Well, basically, if we have found a problem on the female side, whether it's fibroids, endometriosis, polycystic ovaries, ovulation problems, we treat those first with medication or with surgery. Usually it's keyhole surgery, so it's not very debilitating. Patient comes in the morning, has the surgery, goes home the same day. 1 week later, she's playing tennis, even if she didn't play tennis before. But with once we've corrected the physical factors, physical pathology, if despite that they don't conceive, then we have to assume that there's a problem with the egg quality, and then we move to in vitro for the female factor. Whereas for males, if the sperm count is below 10 million, below 5 million, any treatment is a waste of time other than in vitro. Mm-hmm. The sperm count is not too bad, between 10, 20 million, then we can do our intrauterine insemination, or artificial insemination with the sperm, where we spin, wash the semen, turbocharge the sperm, and use high-speed sperm and deposit it in the right place at the right time. So this is less expensive than in vitro, but most of the time for male factor, we do need to resort to in vitro.
Yes, and so we were saying that, donc là, Dr Goswami peut dire nous, qui, dans un problème infertilité, dans 50% des cas, dans 50% des cas, servit la technique in vitro pour régler un problème, la qualité du ovum et la qualité du sperme, et qu'en général, donc, c'est une technique très, très courante. C'est pour ça qu'il y a le docteur Nawaz aussi, qui est un expert dans in vitro, et qui a nous pour causer les différents aspects de sa procédure-là. Mais, là, le docteur Goswami, how important is technology? You know, because we see that very, very often Mauritians, they choose to do their treatments abroad in India. I know many people going to Chennai, etc. Is it that we do not have the means in Mauritius? What is the role of technology and resources in such infertility treatment?
We have all the technology available here. And I think the main reason why some patients are still going abroad is because they believe that it's perhaps less expensive. Actually, what we charge here is less than 30% of what we were charging in UK. So I don't think it's true that it's less expensive abroad. All the technology is available. In fact, we have more advanced technology than the majority of centers in India, where we have time-lapse incubators to assess embryo quality, embryo development. We have ultrasound machines which provide 3D and 4D images even in pregnancy.
So tell me, help us understand, doctor, what happens when you opt, when you choose when you decide that this couple needs in vitro treatment? So what happens from that point onwards?
At that point, once we decided, and once the couple have decided and agreed that they need in vitro, we then arrange an appointment for what I call a pre-treatment appointment. We don't charge for that. This appointment is with one of our doctors. It's for what we call implications counseling, to explain to them what is going to happen during their treatment. We have booklets that we get them to read in advance. But then the whole process is explained to them by the staff, and then they can choose which month they wish to have treatment. They can say, we're now next month, or in 2 months' time, or 3 months' time, and then we adjust the medication to try and get eggs, as many eggs as possible.
And do you stimulate the body for it to produce more eggs?
Yes, what normally happens in a natural menstrual cycle, there are several eggs that have some potential to grow each month. Normally one egg grows and the other eggs die off. That's why humans have one baby at a time, not like puppies. Mm-hmm. Whereas with in vitro, we want to get more eggs, to get more embryos, to get a better chance of pregnancy. So we then use drugs, hormone drugs, to stimulate the ovaries, to try and get the whole group to grow. And if we can get 8 or 10 eggs, we're not going to get 10 embryos, but from 8 or 10 eggs, we end up with 2 or 3 first-class embryos. We put 2 embryos back at a time, and the chance of pregnancy with 2 embryos is higher than with 1 embryo. But if we just put 1 embryo in somebody aged 30, a chance of pregnancy is maybe 20-25%. In the same patient, we put 2 embryos, the chance of pregnancy is 45 to 50%, and the risk of twins is about 10%.
Okay, so when somebody is doing an in vitro treatment, there's a very high chance, significant chance, that they're going to have twins.
Yes.
But we see, doctor, that some couples, they are a little bit concerned about hormonal treatment. So you're talking about stimulating the ovary to be able to produce more eggs for the in vitro treatment. But how safe is hormonal treatment when you're stimulating the body?
We do blood tests before we embark on the treatment. In very, very few patients, there is a risk of getting too many eggs, of hyper-stimulating the ovary, of overstimulating the ovaries. And so we try and screen these patients out before and use very low-dose drugs on them. Despite that, in some cases, maybe in 2% or 3% of patients, we can get what we call hyperstimulation. And if they have too many eggs, then to avoid hyperstimulation syndrome, which is a complex and not a pleasant condition, we freeze the embryos and replace them subsequently so that they don't develop complications of that. So the risk of complications is very, very low, but it is there. It is explained in the information booklets that are given to patients to read beforehand, so they are aware. Mm-hmm. During the treatment also, we warn them, if you get any of these symptoms, etc., that you must report to us, and we will then take preventive measures.
And in the long term, does hormonal treatment have an impact on the general health of the person?
Not really. There was a rumor about 20 years ago that women who have been on the pill, contraceptive pill, have a lower risk of ovarian cancer than women who've had fertility treatment. But in fact, this was discarded many years ago by all the scientific authorities to say that there was no real data on it. There's no reason why the hormones that we use are similar to natural hormones, which stimulate the ovaries. And when the ovaries stop making eggs, when they have no more eggs, the woman's FSH levels rise sky high. We're using low doses of FSH in women who are fertile or who are still reproductive. So there's no real high long-term risk from these medications.
Donc là, c'est que le docteur Goswami peut dire nous quand une fois qu'un couple décidé pour utiliser la technique in vitro pour être capable de tomber enceinte, donc ce qu'il fait là, l'hypobisien prend madame là, l'épouse, et stimule ce l'écho pour qu'il y produise beaucoup plus d'ISF qui normalement, parce que normalement, l'écho, madame, il produit un seul d'ISF dans un mois, et les restes d'autres mots. Donc, ce qu'il fait, c'est servir un hormone pour stimuler l'écho, produire et retenir beaucoup plus d'ISF qu'après, je extraire pour faire sa traitement in vitro là. Et en général, quand une madame peut faire une implantation, ce sens pour qu'un embryo réussit, 20%, c'est ce que le docteur dit à nous. Donc, c'est qu'ils fait en général, ils mettent D. Et quand on met D, et nous tous connaissons, Bandimoun qui a fait traitement in vitro, c'était un grand sens, c'était un sens à peu près 10% gagne ban jumeau. Et là, on pose le docteur la question, on demande est-ce que ce traitement hormonal là, est-ce qu'il est correct, est-ce qu'il est safe pour une madame faire ça? Et il dit à moi oui, sauf dans le cas que madame là est capable d'être hyper productive. Et là, je te fais un thé savant pour guetter qui manière capable de gérer la situation. Mais le risque, un petit risque, il toujours existé. Et là aussi, on demande le docteur, si pas à long terme, est-ce qu'il y a un traitement hormonal là, il y a un impact sur la santé de madame. Et là, il dit à moi qu'il longtemps, plusieurs années de cela, il y a une mauvaise conception qui a un traitement hormonal capable de produire un cancer ovaire. Et il dit à moi que ça, aujourd'hui, il est complètement faux. C'est la science, il montrait qu'il peine ça qui a été risque là. Donc, nous nous rentrons un peu dans le vif du sujet, un traitement fertilité là. Et nous pouvons causer un petit peu plus là avec le docteur Nawaz après la pause. Donc, je me retrouve tout de suite après la pause pub.
Harley Street Fertility Centre, Mauritius, is the only dedicated fertility centre on the island. More than 1,500 babies have resulted from treatment here.
Hello, I'm Dr. Salgar Sarfaraz. I work in Harley Street Fertility Centre as a consultant gynecologist and obstetrician.
Donc, on va la pause, nous type cause un petit peu plus en détail le traitement in vitro et comment ça passait. Donc là, nous avons le docteur Sarfaraz, lui qui est un spécialiste justement dans ce traitement in vitro là. Donc, I would ask Dr. Sarfaraz, now we have talked about how we take the egg, how we take the sperm, and how the fertilization occurs. But now, tell us a little bit more about the transfer. How do you transfer the embryo into the uterus?
So what we have in our clinic is something called as time-lapse machine, where we follow the embryo from the fertilization till day 5. Each embryo is monitored very
Day
closely.
5 is when the transfer occurs.
Yes. Day 5 is the stage where we call as blastocyst of the embryo, where we transfer it back. So we time-lapse the embryo. We have special incubators as a camera, and it keeps on monitoring over 5 days. And in a nutshell, it shows us which is a good quality embryo. So 2 best good quality embryo goes back on the day 5 at the blastocyst stage.
Voilà, donc là, c'est qui Dr. Sarfaraz peut dire nous, c'est qui une fois que fertilisation est arrivée, donc quand fertilisation arrivée, ben là, je veille ça et je veille ça en bas de microscope et je guette live comment ça peut passer. Et une fois quand ça arrivé, quand il y a une fertilisation, là, une cellule vient D, D vient 4, 4 vient 8. Et ce processus ça, il prend à peu près 5 jours. Donc this is what you're telling us. It's after 5 days,
Yes.
it becomes 8 cells.
No, it becomes a blastocyst. 8 cell stage is day 3. The first day is a fertilization. The second day, when we see, it should be 4 cell. The fertilization means 2 cell. Then second day is 4 cell. Third day is 8 cell. So at this 8 cell, if you want to do some genetic testing on this embryo,
So tell us about the
done.
genetic testing. How does it happen?
See, we have a special equipments for this. It cannot be done in any IVF center. It has to be having something called as ICSI machine, where the embryo is held with a microscopic pipette, and 1 cell is withdrawn from that at 8 cell. So 1 cell, it has all pluripotent cell where it can be tested. So now in our center, we do chromosomes like 18, 13 and 21 testing, and even gender selection XX and XY. So these testing are available at our center.
And what does this test detect?
Down syndrome, the most common, as Dr. Goswami mentioned, that as age is an important factor in female reproduction. So as the age increases, the chromosomal problem increases, and the most common chromosomal abnormality is Down syndrome. That's chromosome 21, which can be easily detected in our center if a woman in his previous pregnancy had Down syndrome, or such issues can be sorted out.
OK, donc là, c'est qui docteur peut dire nous, c'est qui le 3e jour. Donc le 3e jour, dans l'embryon là, déjà, il y a 8 cellules, et c'est qui je te faire microscopiquement, je t'extraire une cellule là-dedans et que je t'allais lire ban chromosome dans sa cellule là. Et quand je te lis, c'est qu'il y a dans ce ban chromosome là qui ça permet de nous trouver, qui ça embryon là, c'est un embryon, un garçon ça, ou soit une petite fille. Donc là, ce qu'il peut dire nous, c'est qu'il y a un couple qui vient de pour faire un traitement. Vous êtes capable au départ même choisir si pas vous avez envie de gagner un garçon, ou soit vous avez envie de gagner une petite fille. Dans certains pays, comme dans l'Inde, c'est pas une pratique illégale, mais dans Maurice, l'illégal, et il y a aussi les autres numéros chromosomes qui se lire et notamment qui sont capables de détecter si pas ça embryon là, il y a Down syndrome, et il est là, je capable de choisir qui embryon je peux servir. Yes, doctor, you wanted to say something.
Yeah, I mean, the reason we provide embryo screening and pre-implantation diagnosis is to decrease the risk of abnormality, decrease the risk of miscarriage. And it's offered to patients above the age of 40 generally as an option if they had miscarriages or repeated failure. As far as the X and Y is concerned, there are many abnormalities with the X chromosome which are also result in miscarriages, and so we can pick up those. So on the side, yes, it's possible to determine male and female embryos. But if somebody comes with a request that they want a boy, if they've had 2 girls and want a boy, or have a girl and want a boy, or the other way around, it's what you call family balancing, then we can provide that. But generally speaking,
It's not the service.
for somebody who comes first time for treatment and says,
Yeah.
I want you to do a selection of embryos, I say to them, take what you get, and we'll try next time to do the other, because
Cost-wise.
a son is a son till he gets a wife, and a daughter is a daughter for life.
Okay, you're getting very philosophical here, docteur. Donc là, le docteur précise-moi que normalement, le choix un garçon ou soit une fille, c'est pas généralement une chose qui est encouragée. Je te fais aller quand il y a un besoin pour équilibrer une famille, etc. Mais le screening embryonnaire, je te fais aller seulement, surtout, pour qui diminuer le risque de miscarriage, diminuer le risque qu'il y a une mauvaise grossesse et surtout diminuer le risque qu'il y a une abnormalité dans les enfants qui peuvent éventuellement prendre naissance. Donc, tout ça, c'est une technologie qui existait aujourd'hui et qui existait dans Maurice et qui pratiquait dans Maurice. Donc, tout de suite, moi, pour aider mon Dr. Sarfaraz, là, Dr. Sarfaraz, we hear a lot about the embryo transfer that happens, and we hear a lot about unsuccessful embryo transfer. Tell us a little bit more about that.
See, as once the embryo is transferred, its next 48 hours are crucial. It's when it hatches and implants. So these 48 hours determine whether a woman is pregnant or not pregnant. And implantation is natural. It's not in our process. They have tried many other ways like using a glue and all. It's not at success. So it's the same. So as I told you, the age plays an important factor. Previous fertility, if there were some 1 or 2 pregnancies before and it were term, this enhances the implantation.
What are the chances of implantation? Do you have a number there?
Number, it's again on the age wise. It's between the age of 20 to 30. As sir said, the success rate is 45 to 50% maximum which it can go. So yes, the success rate is 45%, I can say. In that, twins is 10%. Again, from 30 to 35, it ranges from 30 to 35%. So again, as the age increases beyond 40%, it comes down to 10%.
Okay, so it is then the implantation. It is at that point that the probability factor intervenes.
Yes.
So how many times?
Let me add one more thing. Even after implantation, this is a positive test. Some pregnancies may not carry because what we are transferring is as natural as a natural embryo. So some pregnancies may miscarry. As in natural pregnancies, what happens? Same thing in vitro as well.
Okay, so how many times normally in a normal in vitro treatment does the transfer process happen? How many times do you do it normally with a couple?
It's once transfer. There's nothing like multiple transfers or anything.
You don't do it after 1 month, and if it doesn't
depends.
succeed?
If we are transferring a fresh embryo, it's in the same cycle. After the stimulation, we retrieve the eggs, and we did it after 5 days of egg retrieval. Then if we freeze her embryos, we do it in the consequent cycle. Suppose the cycle fails. If the couple had a few frozen embryos left from the previous cycle, we can use it whenever the couple is ready.
Yeah, but it increases the chances, no?
It's the same.
It's the same, because if you have 50% the first time, if you have 40% the first time, and the second one 40%, the third one 40%, then the probability...
Yes, the probability goes up statistically by mathematics, but the implantation remains.
But nature is not always about statistics.
Yes.
Yeah, yes, doctor.
Yeah, what you were just saying is what you call the cumulative pregnancy rate. The cumulative pregnancy rate from one IVF treatment, if they have embryos frozen, jumps up from 40% to 60-65%. But if you say every time the chance of pregnancy, let's say, is 40%, you have 100 couples, 40 will conceive in the first treatment. Out of the remaining 60, 40% will conceive in the second treatment. Of the remaining 25, 40% will conceive in the third treatment. So now you have a cumulative pregnancy rate. But mathematical formulas only happen when all factors are equal and all embryos are not the same. So this way of juggling figures is what some centers in the world are presenting as 80% cumulative pregnancy rate, 90%, and patients' hopes get falsely raised.
And
So
it is not
we
very...
try and avoid talking about cumulative pregnancy rates.
Okay, so that's very important. Donc là, ce qui nous peut causer, c'est que normalement, si une madame est en 40% de chance qu'il ça embryon-là, il peut implanter dans ce système et il peut développer, il peut venir un petit baba. Donc, nous peut demander, docteur, s'il fait une fois, il fait deux fois, il fait 3 fois, il fait 4 fois, est-ce qu'il se sens pour gagner un petit bébé, il augmente. Il dit effectivement, il augmente, mais c'est moi, il ne faut pas nous trop compte lorsqu'on a été calcul probabilité mathématique là, et si à tout, dans ça qu'a été processus là, parce qu'il nous connaît qui, dans cas traitement fertilité, c'est quand même aussi un processus psychologique. Il y a beaucoup de choses qui déroulaient dans la tête, ban famille, ban couple, et faut des pas, et docteur, il peut mettre un gros emphase là, extrêmement important, qui nous pas donne ban couple, ban fausse l'espoir, faut des l'espoir, li tout le temps reste mesuré. Mais il y a aussi le fait que, normalement, quand une madame li tombe enceinte, et non un monitoring qui fait bien veiller, bien guetter, bien assurer qui pregnancy là, qui grossesse là est pas correct. Est-ce que donc là moi peux demander Dr. Sarfaraz, Dr. Sarfaraz, for normal pregnancies, it's already very complicated to monitor and to treat the mother so that the pregnancy happens in the best conditions, right?
Yes.
But an in vitro or an in vitro induced pregnancy, does it require more monitoring, more care?
Yes, certainly in the first trimester. Yes, because there will be something, some spotting, bleeding, which creates the attention. I mean, the couple are more apprehensive. So we do early scans. Depends if the fetus is healthy in the first scan. When we do around 6 weeks, we see a fetal pole, we see a heartbeat of the fetus. That assures us, yes, it looks a good regular gestational sac, the ultrasound finding. Then we call the couple again after 2 weeks to monitor how they go in the first trimester. So that is important. Yes, early monitoring, and see, not only when we have transferred 2 embryos, we need to confirm whether it is a single or twins, whether it is in the right place is also important. Yes, with advent of in vitro, yes, the risk of twins is increased, the risk of ectopic pregnancy is increased. So yes, we have to monitor them closely in the first trimester.
Okay, and is there any special treatment that happens during that period? Sometimes is it required highly technical interventions? Is it required normally during that time?
Yes, certainly at 13 weeks, as one of the important factor is age. Again, this will be the last time I'll be speaking about the age. So as the age of the what patients we deal is about 35, more common. So the genetic screening and all is also required. So around 11 to 13 weeks is when we do a nuchal scan to see and rule out as much as anomalies we could do in the early scanning. So it's said about 75 to 80% anomalies can be picked up if you do a proper first trimester scan between 11 to 13 weeks. Then also we subject some blood test, which is called as harmony test, where a mother gives a blood and we extract the fetal DNA to map the chromosomes of the fetus as well. So yes, definitely these things are available and we do it.
So the time span for an infertility treatment is it's a question of months, several months. The diagnosis process, the application of the solution that have been chosen, the pre-fertilization phase, the post-fertilization phase, the transfer phase. So how long usually a couple who goes through, for example, an in vitro treatment, how long does that person remain under your care?
See, if you say if a couple is coming for a first time consultation and all, it depends what is happening, whether they are subjected to any pre-in vitro procedures, like to, if there is some, I mentioned, if there is endometriosis or fibrome, which we treat and then we go for in vitro. But in vitro generally happens in one cycle. One cycle means as a menstrual cycle. We start the treatment on the second day of a cycle, and around 14th day, 12th or 14th day, we retrieve her egg, and after 5 days, we do embryo replacement. The next 10 days is when we wait and watch for her result. If positive, yes, it's a pregnancy and it has to continue for 9 months. It's a nature, we can't bring them early. So yes, it's like that.
Voilà. Donc là, nous pouvons dire que ce traitement fertilité-là, c'est tout un processus. Donc, et non d'abord la phase que vous faites un diagnostic, après, et non la phase pré-fertilisation, que vous commandez une cause étalée là, vous stimule la production d'ISF, et que vous faites fertilisation, vous faites le transfert. Après ce transfert-là, il y a une phase que vous surveillez si pas l'implantation là peut déroule correct, et qu'après l'implantation là, ben là, la dame, la mère, elle connaît qu'il est enceinte et quand elle connaît qu'il est enceinte, elle a tout ça processus, pareil comment un dimoun qui tombe enceinte normal, il besoin de traverser avant qu'il y gagne ce petit bébé, mais seulement surtout dans le premier mois, dans le cas côté d'une insémination artificielle et d'un monitoring qui est encore plus serré qu'il besoin faire pour assurer que tout passe correct. Mais tout ça là, Francesca, comment? Pour une madame, il est quand même compliqué, non? Un traitement fertilité, il y a un processus qui est un peu invasif, comment dire, il rentre dans l'intimité du monde là et il y a l'effet, l'os mental, etc. Donc, est-ce que dans la clinique là-bas, il y a l'accompagnement? Est-ce que vous avez un type d'accompagnement pour ces dames? Comment vous traitez ce problème?
Donc déjà au début, on rencontre les patientes, je rencontre les patientes, je les mets à l'aise, je leur explique un peu comment ça va se passer avec la consultation avec le docteur Goswami. Et si le besoin est, je les accompagne aussi pendant la consultation pour qu'elles se sentent à l'aise pour poser des questions. Et bien souvent, quand elles ne réussissent pas, parce que c'est un investissement financier, investissement émotionnel, donc c'est assez dur pour la patiente et aussi pour le couple, parce que c'est un sujet tabou, elle n'arrive pas à parler avec des amis, la famille et tout. Donc, on est là, l'équipe est là pour les écouter. Donc, moi aussi, j'essaie si elles ont des questions, il y a beaucoup aussi qui refusent d'en parler. Mais si les patientes veulent parler, je suis là, je les écoute. Et aussi, nous avons Tessa, un psychologue qui peut leur conseiller, les écouter aussi, cheminer avec eux pour les aider à surmonter cette épreuve. Et aussi, nous avons la doctoresse Garou Sankar et Cathy l'infirmière qui les accompagnent aussi dans tout le processus du traitement aussi et pour les expliquer les implications du traitement, les expliquer comment faire des injections et tout.
D'accord. Donc, tout ça, vous avez donc un encadrement complet pour accompagner les couples, pour accompagner les dames et pour que tout se passe aussi souplement que possible.
Oui, et surtout quand elles ne réussissent pas. C'est très dur. Donc, le docteur, après une semaine, les rencontre pour leur expliquer, parce qu'il y a une investigation qui se fait. Donc, le docteur leur explique un peu pourquoi ça n'a pas marché et quelle est la prochaine étape aussi. Donc là, en ce moment, nous accompagnons les patients, nous les écoutons aussi pour voir s'ils ont des questions aussi et comment ça se passe.
Donc, merci beaucoup, Francesca Comarmon. Et là, je vais me retourner tout de suite vers le docteur Goswami. Le Dr. Goswami, is surrogacy a practice in Mauritius?
No, surrogacy is not allowed here, just as it's not allowed in many countries because it has too many problems. In the UK, for example, surrogacy is allowed, but there the couple having in vitro, their embryos are implanted in a surrogate woman who is providing a uterus, a womb as a host. But by law, that the woman who gives birth to the child is the legal mother. The commissioning couple then have to apply for a parenting order and adopt the child. This is where the problems occur, because if the woman decides to keep the child, we have serious problems. So surrogacy is a much more complex issue. It's not allowed here. And I think it's a good thing that it's not allowed. There are very, very few patients who need surrogacy. Women who've had a uterus removed for cancer or whatever, cancer of the cervix, so heavy bleeding, big fibroids. I have treated patients with surrogacy in the UK, and it's usually a sister who would host for the sister. Commercial surrogacy is illegal even in the UK, so you cannot pay a surrogate. In India, it's possible, but this was being abused by foreigners, and India has now banned surrogacy for any foreigners. I know it's happening illegally, but it's not supposed to.
Ok, donc là, la question qui me pose le docteur Goswami, c'est est-ce que ma mère porteuse, c'est une pratique qui est permise à Maurice, mais effectivement, disais-moi que c'est une pratique illégale dans Maurice et qui longtemps sinon une pratique commerciale, hein, que man a payé bandimoun, ban mère porteuse pour de jeunes enfants dans certains pays, par exemple dans l'Enzodi, la pratique de mère porteuse pour faire li pour un étranger, il n'est pas permis. Donc, il y a de plus en plus de contrôle sur sa quitteuse-là. Mais là, quand nous allons au site web, harleystreetfertility.com is your website.
No.
So, when we go on that website, there's a tremendous amount of information already. We talk about semen analysis, laparoscopy, heteroscopy, blood tests, ultrasound examination, and donor eggs, donor sperm, etc. But I find something that probably you might need to explain to us, doctor. There is something called testicular tissue freezing. What's that freezing thing?
Basically, there are some men who do not produce any sperm in their ejaculate. So these are men who have what's called zero sperm count or azoospermia. In these men, they're often still producing sperm within the testes. So we actually operate on the man. We remove some testicular tissue, which is a few tubules, it's less than 2-3 millimeters of tissue. We then analyze this tissue for sperm. If there's sperm present, we can freeze this tissue so that the sperm can be used from that tissue to fertilize the wife's eggs in future. So the commonest reason for this in the West, in the UK, for example, was men who had a vasectomy, got divorced, now they remarry. And so even in those men, we can take their sperm. But there are other men who were born without a vas, without a tube coming out of the testes, or who are producing sperm in the testes but not in the ejaculate. So for those, we can freeze some testicular tissue and use this sperm from that to fertilize their wife's eggs.
And are embryos also frozen?
Yes. Generally speaking, we would try and stimulate eggs to try and get as many embryos as possible. We replace 2 embryos initially, and any spare embryos, which are of good quality, are then frozen to be used by the couple subsequently.
Is it done systematically?
Yes. If the patient is pregnant with the first treatment, she can come back in 1 or 2 years, have a second child from the same batch of eggs. If she's not pregnant with the first treatment, she can have a second or third attempt of in vitro with frozen embryos, and that will at a much reduced price and much reduced cost because all the hard work has been done initially with the lab. So frozen embryos are frozen at minus 196 Celsius. They're frozen solid. Whether they're frozen for 1 hour or 100 years makes no difference to the embryos. We get patients to consent for 5 years initially for embryo storage. The same way we can freeze eggs and we can freeze sperm. And this is all something that is done routinely in fertility treatment.
How new is this technique, doctor?
Sperm freezing has been around for 50 years. Embryo freezing has been around since 1984-85, so that's almost 40 years.
So we do it now in Mauritius?
We do it routinely. We've been doing it routinely for all this time. Egg freezing initially was not very successful, but over the last 5 years has become extremely successful. I think it's important that couples, that young boys and girls who develop cancer, for example, and need cancer treatment, chemotherapy, radiotherapy, we can now freeze their sperm and freeze their eggs for future fertility preservation. And this is something that is important because not everybody, I mean, the women at 22, 24 diagnosed with breast cancer, for example, chemotherapy will render them sterile. These are the women who should be able to freeze their eggs so that once they've gone beyond the 5-year survival rate and have survived their cancers, they can still have children from their own eggs rather than going for donor eggs or donor sperm. The same way with men.
And how we're reaching the end of our program, doctor. I just wanted to ask you how you see this field of fertility treatment evolving in the future? Where's science going with this?
I think technology is becoming more and more accessible. And it's possible that in future we'll be screening embryos for many different diseases, especially lethal diseases, which one can then treat. And that maybe we can increase, we already increased the natural fertility rate in the human species with in vitro. Maybe we can improve or decrease the risk of abnormality in the babies conceived naturally or with in vitro by testing.
Ok. Donc là, c'est qui docteur Pédianou comme ça, qui zodi et non technologie dans Maurice, code capable congèle sperme, code capable congèle disef, et que même un embryo capable congèle zot, et qu'à congèle zot pour un très grand nombre l'année. Donc c'est quelque chose qui est extrêmement intéressant pour Bandimoun qui peut faire un traitement in vitro quand je finerai ici produire plusieurs embryons, je suis capable de garder ce embryon là et que c'est évident plus tard pour faire une implantation si premier là peine réussi. Et puis aussi pour les jeunes en général qui parfois je besoin faire un traitement chimiothérapie etc. et je tenais un traitement qui est très très radical pour faire qui est capable d'impacter les autres fertilité. Donc avant je t'ai faire ce traitement là, je congèle je ban sperme et je ban disef pour qu'il est capable de servir après pour faire un traitement in vitro. Et moi fin aussi demande le docteur quand l'y penser, zodi, traitement fertilité, peut aller dans quelle direction l'y penser, traitement fertilité, peut aller. Donc, l'idée, moi, qui essentiellement, c'est qu'ils se déjà peut faire, je déjà, comme on dit, aller là, dans ça, après 3 jours, quand il y a 8 cellules dans sa embryon là, je prends N cellules et qui, je lie à un chromosome, et docteur Goswami peut dire, moi, qui dans les temps, avec les temps, dans le futur, je suis capable de faire une lecture beaucoup plus en détail de sa manne chromosome-là, et avant qu'ils implantent sa manne embryo-là avec une madame pour qu'il y développe des petit bébé, je ne peux pas finir de connaître une caractéristique ces enfants-là qui étaient, et est-ce que c'est un enfant qui peut développer normalement, est-ce que c'est un garçon, est-ce que c'est une fille, est-ce que c'est un enfant qui peut non certaines bonnes maladies, et je suis capable de finir prendre bonne disposition pour minimiser sa bonne caractéristique-là, et que dans le futur, ça peut de plus en plus évoluer, les pouvines de plus en plus perfectionner. Donc, la question qui est celle-là, me propose le docteur, docteur, aren't we playing God now with all this? So, what we're doing, we're reading chromosomes, and we trying to make a perfect human race? Is it something we see this in science fiction movies? Is this what we're trying to do? What science is trying to do?
Now, what we are trying to do with fertility treatment is we're increasing the fertility for a couple more than what nature would. What we're trying to do with screening of embryos is to decrease the number of abnormal babies being born. And so to decrease the misery of couples having an abnormal child means other children will also suffer. So we're trying to decrease the abnormality rate. We're not trying to say we want to make the perfect child and therefore we're going to adjust everybody's genes. We cannot change the human genome. We cannot change the basic DNA in the human. But what we can help is if we can diagnose abnormalities and avoid those, then we're increasing the chances of a normal child.
Conception.
Nobody is trying to increase or make a perfect child without any diseases ever. No.
Okay, so we have reached the end of this program today, and then I will ask Dr. Goswami, do you have a word for our people, our listeners, people who are watching and who want to have recourse to such treatment? Any advice for them?
The advice is very straightforward. Number 1, make sure you get a clear diagnosis. Number 2, there's no need to travel abroad. Everything is available here. And number 3, don't raise your hopes falsely. Look at the figures, look at what's happening, and understand what's happening before you go embark on any treatment.
Thank you very much, doctor. Donc, nous finissons au cours de ce programme-là. C'est couvert plus grand nombre de sujets le traitement infertilité et nous espérons qu'il nous aide ban auditeurs et ban téléspectateurs Télé Plus comprend un petit peu plus qui ban implication traitement fertilité et qui manière capable aide ban famille qui pas réussi gagner des enfants get la science qui est capable de faire pour eux et guetter qui ban solution qui se tena à leur disposition. Donc c'était l'émission Mieux comprendre aujourd'hui et me remercier ban interlocuteur, ban expert qui nous filena l'eau plateau aujourd'hui. Thank you a lot, Dr. Goswami.
Thank you for having us.
Thank you, Dr. Sarfaraz.
Thank you.
And thank you also, Mrs. Comarmont.
Thank you very much.
Merci à nous, ban auditeurs. Merci pour votre attention et nous va retrouver plus tard pour une autre émission Mieux comprendre.